Hi there, I'm Doug Kondziolka. I'm a professor of neurosurgery at NYU Langone Health here in New York City and also a professor of radiation oncology. I'm really delighted to be here with you for this important symposium supported by the Chordoma Foundation on this very important array of topics in the care of patients with chordomas. And I hope I can contribute. Wish I was there personally with you, but I'm away at another neurosurgical meeting weekend. Dr. Sen has asked me, and the program committee has asked me to speak on the topic of gamma knife radiosurgery for chordoma. I've had a long interest in chordoma management utilizing stereotactic radiosurgery or other energy delivery types. And of course, the field goes back to the early days of radiosurgery at the University of Pittsburgh, which was the first center where I worked for a long time. And we published some of the initial experience on the use of very precise focused radiation for selected tumors of the cranial base back in 1991, in fact, and then in 1998. But if one really looks at where the modern field of radiation begins, it's with proton therapy in this initial paper from the Harvard Joint Center in 1989, using the charged particles of protons. And in fact, I had worked there as a student back in 1984. And of course, the role of proton therapy has continued in its extremely important role for patients with chordoma over the last decades. I want to start with showing you this patient here. She's a recent patient of ours, is a 69-year-old woman. However, she's had recurrent multiple chordomas and had a prior endonasal resection, then proton radiotherapy, and then she developed recurrence outside the proton field and underwent a second resection after progression. And what you can see in this image of a radiosurgical plan, the target on the left side of the skull base outlined in yellow is recurrent chordoma at the petrous apex, as well as a second tumor on the right side near the tentorium. This is sort of the ideal case for radiosurgery of a small volume recurrence. However, a number of months later, after those tumors initially responded, she had recurrence at other locations and additional radiosurgery was needed. And at this point, we were concerned that she was going to get further subarachnoid spread, and multiple clinicians were involved in the decision-making. Do we continue with radiosurgery? Do we get involved in drug therapy trials? And so on. Fortunately, on her next scan, all of this had responded well, now 2 and 10 months after radiosurgery, and she's being observed further. So these tumors are extremely challenging, as we know, and often this multimodality approach is needed in the life of the patient. And a number of years ago, on behalf of what later became the International Radiosurgery Research Foundation, a multi-center study was put together with a median follow-up of 5 years on 71 patients with chordoma. The average tumor volume was 7 cc's. This is a lot smaller than the typical initial proton radiotherapy field. And it's important to know that when one looks at radiosurgery, one always is thinking of smaller volumes as opposed to the large field fractionated proton or photon approach that has been done. And of course, there's a lot of literature on the value of that technique. So in our study, the purpose was to look at survival, tumor control, complication risk, which can be significant even in patient protons, and variables that predict outcomes. And you can see the number of institutions that participated in this study. And of course, no center has a very large experience with hundreds of patients. You can, as I mentioned earlier, most of the time the tumor volumes are relatively small. And you can see that most patients had 1 prior open surgery, but some had 2 and others had higher numbers. Many of these people had prior fractionated radiation therapy, as you can see, as opposed to initial radiosurgery. Average age was 45. And as I mentioned, the follow-up after radiosurgery was an average of about 5 years, as you can see here. And typically the dose given to the edge of the tumor is a range of 15 gray, which is an extremely safe dose in tumors adjacent to the brainstem. And when we looked at the tumor response in this series, again, these were solid tumors, not the resection bed of after prior debulking. 32% eventually had progression of disease, and about 68% had stability over the course of that 5-year follow-up assessment. So this is the kind of imaging one expects: a smaller volume, recurrent tumor, ideal for a radiosurgical plan. And here's a 9-year follow-up assessment with the regressed remnant in someone who had undergone prior endoscopic endonasal resection beforehand. You can see that overall, when one looks at proton 5-year survival rates in the range of 80%, the results with radiosurgery are very similar. You can see 76%, really not significant difference between radiosurgery and proton radiotherapy. But again, these are different tumor volumes. When one looks at progression-free survival, protons 5 years is about 70%, with radiosurgery 66%. The numbers are very similar. And the factors that affect patient survival have been younger age, a shorter interval between resection and the radiosurgery, fewer numbers of operations, which is a sign of a less aggressive disease progression, of course, and no prior radiotherapy. So if one looks at the big difference between patients who have not had prior radiotherapy and had primary radiosurgery, they are doing better than people who have failed prior radiotherapy. Obviously, failing prior radiotherapy is a sign that the disease is progressing and maybe more aggressive. And patients who are well clinically have less of a neurologic deficit do much better than patients with multiple neurologic deficits. And as I mentioned, tumor volume and age are important drivers on outcome. And here's the data on tumor volume, less than 7 cc volumes, which allow a higher radiosurgical dose lead to a better outcome. Functional outcomes after radiosurgery have been, I would say, adequate. You can see worse here in about a quarter of the patients. The usual cause of delayed deterioration, unfortunately, it can be tumor progression, either in the treatment field or adjacent new sites. Adverse radiation effects are fairly uncommon with radiosurgery because of the smaller volumes and the appropriate dose selection. So fortunately, radiosurgery has not led to a significant number of radiation-related complications for chordoma. And you can see that in this series of, as published, only 9% of patients developed an adverse radiation effect, and most of these related to a focal cranial neuropathy. And of course, when they progress, many go to a further resection, sometimes more radiosurgery, sometimes more radiotherapy as needed. So younger patients, shorter interval between resection and radiosurgery, less prior surgery, no prior RT, these are all good predictors of radiosurgery outcomes. Now, there are other reports as well as the literature grows, but since this is a rare tumor, no series, no institution tends to have a large, overwhelming volume of data to contribute. This article from Korea 2014 shows similar outcomes to what I just showed. And this more recent article from 2021, looking at chordoma outcomes, showed outcomes comparable to proton beam radiotherapy in properly selected patients. Again, volumes less than 7 cc's give the best long-term survival rate, exactly what was shown in the American series. This is a recent study from Japan looking at surgery and gamma knife radiosurgery as needed, and facilitating aggressive resections leading to smaller volumes, allowing radiosurgery to be offered to patients as needed. So this multimodal approach, including resection and radiosurgery, seems to provide the best outcome and the best chance for cranial nerve preservation and best functional outcome for our patients. And seeing smaller tumors with high resolution imaging is necessary to being aggressive with radiosurgery. In my opinion, it appears to be as effective and more convenient done in one session with less morbidity than proton irradiation for small volume tumors. And with that, I thank you for your attention and wish you the best in the symposium for the rest of the day. Thank you very much.